Welcome to my YouTube channel. Today we're going to talk about pre-existing diabetes mellitus in pregnancy. Kindly subscribe. It will cost you absolutely nothing. Pre-existing diabetes or overt diabetes mellitus. This is when you had a patient who already had, just from the name, pre-existing diabetes mellitus in pregnancy. So this is a patient who had pre-existing diabetes mellitus before pregnancy. So meaning before the conception occurred, this patient was ill with diabetes mellitus, which could have been diabetes type 1 or diabetes type 2. Just to differentiate from that, diabetes, we have two types of or classifications of diabetes in pregnancy, where we have diabetes pregnancy, that's the pre-existing one, and gestational diabetes, which develops in pregnancy. So the diagnostic criteria for diabetes mellitus is when you have fasting glucose that exists 126 grams, that will exist greater than 7 millimoles per liters, and when you have 2 hours postprandial after taking the oral glucose test, a value exceeding 200 mg per dl, that is greater than 11.0, and when you have HB1C of greater than 6.5. So diabetes related pregnancy complications. These are complications that when we have diabetes, we will develop these complications in pregnancy. So kinda diabetes predisposes a patient to have these conditions. So as you can see here, for example, preeclampsia, it is high in patients who had diabetes mellitus. Stillbirth, it's also high in patients who had diabetes mellitus. In addition to neonatal maternity mortality, macrosomia is a big baby. So when you have hyperglycemia, which will actually be distributed back to the body, which will be distributed through the placenta into the fetus, meaning this fetus will grow and produce more insulin producing fats, meaning we'll have a big baby. Shoulder dystocia, this which is a complication during labor, and then anomalies, which is more in 7 to 9%. Kindly note, in pre-existing diabetes mellitus is when we have predisposing anomalies compared to when we have gestational diabetes mellitus. This is because gestational diabetes mellitus occurs past organogenesis, that is 16 weeks past, after already we have had our organogenesis. However, pre-existing diabetes mellitus is present during organogenesis, so it affects the development of organs. So diabetes embryopathy is what I'm talking about. Its incidence is 6 to 10%. So here it's when you have, as I've said before, diabetes pre-existing diabetes mellitus is when already at conception you have already this disease, and it goes on through pregnancy. So it affects the organogenesis, meaning you are predisposed to higher risk of anomalies. So the anomalies present is, for example, cardiac defects, where you're predisposed to have VSD. You're also predisposed to have transposition of great vessels, hypoplastic left heart. In CNS anomalies, you also have encephaly, spina bifida, holoprosencephaly, and caudal regression. In addition to that, you can also have sacral agenesis. Effects of pregnancy on diabetes. So this is what this statement means, that what are the effects that already we have diabetes. So what are the effects that pregnancy will increase already when we have diabetes? So difficulty in blood sugar level control during pregnancy is due to altered carbohydrate metabolism and impaired insulin action. And this impaired insulin action is due to insulin antagonism due to a combined effect of human placental lactogen, estrogen, progesterone, free cortisol, degradation of insulin by the placenta. So already, for example, we have already an existing problem, but now we are kind of worsening the problem. We already had diabetes mellitus, but now we are worsening this diabetes mellitus. I hope you have understood. In addition to that, insulin requirement during pregnancy increases as pregnancy advances. There is a rapid activation of, so if the insulin requirement already increases during pregnancy, and we have antagonism of insulin, and we have a bigger problem, that is altered carbohydrate metabolism, then, and you have said here, we have we have increased requirement of insulin. This will lead us to rapid activation of the lipolysis with short periods of fasting. So when you don't take meals of a short period, this will lead to lipolysis, leading to ketogenesis. And the risk factors of ketogenesis include hyperemesis in early pregnancy, infection, fasting of labor, fasting during labor, and corticosteroids, which are given in babies who are preterm, because corticosteroids give us a problem in managing glucose. Uh, the insulin requirements fall significantly in puerperium, and then thereafter the patient gets normally. So vascular changes, especially retinopathy, nephropathy, coronary arterial disease, and nephropathy may worsen during pregnancy. So I hope you have really understood when the statement means effects of pregnancy on diabetes. Now let's look on the effects of diabetes on the pregnancy. So how is this diabetes affecting the pregnancy? And you're going to categorize them into fetal and maternal. So in terms of fetal, we have birth defects, and as already said before, that this pre-existing diabetes is in the period of organogenesis, that throughout the pregnancy. And organogenesis occurs in first trimester. So you'll have 3 to 4 increased risk of having birth defects. And we already mentioned these birth defects, which include heart defects, which include VSD, transposition of great vessels, neural tube defects, already mentioned them, birth defects of the brain and the spinal cord. In addition to that, there's increased risk of miscarriage and premature birth. So in addition to that, you'll also have macrosomia, which we talked about, and it is incident is 40 to 50%. This is because these babies grow large, as I said before, because we have already some extra sugar in the mother's blood, which will cross the placenta and goes to the fetus. And then the fetus produces extra insulin, which helps it to process this sugar and store it as fat. And these fats tend to accumulate mostly in the shoulders and the trunk. That is when during labor the head is already out, but we have difficulty in removing the shoulder, leading us to have shoulder dystocia, and sometimes making it difficult for babies to deliver vaginally and putting them on risk of having brachial plexus trauma, shoulder dystocia, and fractures during delivery. Another complication that or another effect that diabetes has on pregnancy is increased risk of stillbirth, and prenatal death is increased 2 to 3 times. This is because prenatal death, this is death occurs at that period after delivery. This is because of hyperglycemia, respiratory distress syndrome, polycythemia, and jaundice. So newborn complication, we already talked about fetal complication. Newborn complication include respiratory distress syndrome, hypoglycemia, because this baby had already had a very good environment of having high blood glucose from the mother. Now it is after birth, and for example, this baby does not feed well. So we'll have incidents where we'll have hypoglycemia, hypocalcemia, hypomagnesemia, polycythemia, and neonatal hypocalcemia as mentioned before, and neonatal jaundice. So in childhood, this baby will be predisposed to have diabetes, obesity, and metabolic syndrome, which is a combination of childhood obesity, glucose intolerance, hypertension, and diabetes as young adults. So now on the mother's side, the effects of diabetes on pregnancy, we're going to start with antenatal, where we'll have increased risk of abortion. That patient will present with having recurrent spontaneous abortion. Preterm labor will be high, 26%. This is because to this is because to predisposing factors such as infection and polyhydramnias. Infections, UTI mostly, high incidence of preeclampsia as mentioned before, polyhydramnias, which is caused by a large baby, large placenta, and because we have already fetal hypoglycemia leading to polyuria. Polyuria will present as polyhydramnias. In addition to that, we already have increased glucose concentration in the liquor, which will affect the amniotic epithelium and also increase the risk of osmosis having polyhydramnias. In addition to that, we have maternal distress, which are effects of oversized baby and polyhydramnias. As we said before, during pregnancy, the vascular complications of diabetes will worsen, and the vascular complication of diabetes includes diabetic retinopathy, diabetic nephropathy, and coronary heart disease. So during labor, the effects of diabetes on pregnancy include prolonged labor because of a big baby, already talked about, shoulder dystocia, already talked about this because this is of disproportionate growth with increased shoulder to head ratio. I've already mentioned the pathophysiology behind this, perineal injuries, PPH, the operative interference because already we have a big baby. During the puerperian period, we have increase of puerperian sepsis and lactation failure. So the management, so our goals of management, we have number one, to maintain this patient in euglycemic, where our fasting glucose will be less than 95, 2 hours postprandial should be less than 120, 1 hour postprandial should be less than 140, and HbA1c of 6.0. So for those who are using millimoles per liter, our fasting should be less than 6, 2 hours fasting should be less than 5, 2 hours postprandial should be less than 6, 1 hour postprandial should be less than 7.8. 8. So how are we going to maintain the euglycemic and these goals? Is by diet, exercise, and insulin, in addition to hypoglycemic medication. So other goals of treatment include minimizing fetal effects, prevention of pregnancy-related complications, preventing patient to enter into DKA, preventing long-term complications such as obesity, metabolic syndrome, as actually they're here, obesity, diabetes, and cardiovascular disease. So preconception care or preconception management, patients should be offered contraception at least to prevent unplanned pregnancy, so that the patient can optimize glycemic control at least 3 months before conception. And then you counsel the patient on having the importance of having good blood glucose control before pregnancy, during pregnancy, to reduce maternal, fetal, and neonatal complication. In addition to that, you advise the patient to optimize weight, and risk of getting diabetic child is 3.3 to 7% if one parent is diabetic, and up to 40% if both parents are diabetic. So to optimize our blood glucose targets, and some patient may require insulin to optimize these targets. As I've already mentioned before, HbA1c should be 6 to 6.5, fasting should be less than 5.3, 1 hour prosperity should be 7.8, and 2 hours prosperity should be less than 6. In addition to that, you stop teratogenic medications such as ACE, ARBCs, and statins. So I'm going to give you an homework. Go and find the teratogenic medications, which include warfarin among others. Thalidomide. Go and search. In addition to that, adequate folate supplementation. You advise the patient to stop smoking. Concurrently, you ensure that the patient has good blood pressure control, that is less than 130 to 80 millimeters of mercury. So you assess for nephropathy, retinopathy, thyroid dysfunction, UTI, autonomic retinopathy, cardiac dysfunction, and manage or refer accordingly. And then you highlight because this patient is a high risk patient, so you ensure that they have regular visits. That is, first trimester they come for monthly visit, second trimester they come to for visits 2 to 4 times weekly, that trimester they come to weekly. And then in addition to that, regular home blood glucose monitoring. You adjust insulin doses depending on the blood glucose, and then you monitor the NC profile, and you need to repeat for screening for complication in second and third trimester using urinalysis, UEC, FBC, and ultrasound. In addition, as you said before, appropriate diet and exercise during pregnancy. So how do you detect malformation? You detect malformation by, number one, first trimester HbA1c. Already we said the malformations will occur in first trimester where we have organogenesis. So a higher HbA1c indicates that we are not actually controlling this glucose. So in addition to that, first trimester screen of alpha fetoprotein at 16 weeks, and the quad screen the quad screen test, which include after alpha fetoprotein, is beta HCG, in addition to that, unconjugated estriol and inhibin A. So it is a test that contains 3 components, as you have said: beta HCG, alpha fetoprotein, inhibin A, and unconjugated estradiol. You also do an ultrasound at 13 to 14 weeks to detect obvious anomalies such as encephaly, among others. You can also do a comprehensive anatomic survey at 18 to 20 weeks, and in addition to that, you can do a fetal echocardiogram at 20 weeks if necessary. So antenatal follow-up: any diabetics on medication will need a growth scan every 4 weeks after 20 weeks. This is because this growth scan is to assess how this fetus is growing. Are we having stillbirth? What complications do we have in terms of the growth of this fetus? So in addition to that, we also have antenatal screening, that is non-test, will need to be started at 32 weeks unless there is intrauterine growth restriction. They will be need to start earlier. And then regular blood glucose monitoring to achieve our targets, which we said HbA1c of 6.0 to 6.5, fasting blood glucose of less than 5.3, 1 hour prosperity of less than 7.8, and 2 hours prosperity of less than 6.7. And then in addition to that, you also do nutritional counseling should be offered during pregnancy. So the glycemic control. So this depends on what type of diabetes that this woman come in, because this is pre-existing diabetes. And we have two types of diabetes. Diabetes type, the major ones, diabetes type 1 and diabetes type 2. Diabetes type 1 is when we have insulin dependence, so the therapy will majorly be insulin. Diabetes type 2 is where we have insulin resistance, and majorly we give this patient oral hypoglycemic agents such as metformin. So metformin and glibenclamide can be used safely in pregnancy as long as the sugars are controlled within targets. However, if the sugars remain elevated, then intensify the therapy must be considered, including switch to insulin therapy. I hope you are okay. And then patients with type 1 diabetes mellitus must remain on insulin therapy titrated to targets. And then due to the changes of pregnancy and increasing weight, and most women will be better controlled on insulin therapy. So I hope you are okay in terms of glycemic control. So we said there are two types of diabetes type 1 and diabetes type 2. So in diabetes type 1, this patient will use insulin. So you continue giving them insulin, and then you titrate according until we achieve the targets. In diabetes type 2, where we have problems with insulin resistance, you can give oral glycemic agents until you achieve, as long as you can control or achieve targets. If you can't achieve targets, then you initiate insulin therapy. In addition to that, we already said that diabetes on itself predisposes a woman to having preeclampsia. So what we do, from week 12, you give the patient low dose aspirin, that is 75 mg OD, should be given for preeclampsia prophylaxis from 12 weeks to term. And then from first trimester, nausea and vomiting may cause hyper and hypoglycemia that would warrant changes in therapy and dosing. And then an ultrasound specifically for fetal anomaly scan should be done, as we said before, 18 to 24 weeks to rule out congenital anomaly. And then monthly scans should be done from 28 weeks till term to assess fetal growth and amniotic fluid index to assess polyhydramnios. And if it is greater than 25, this is an indication of polyhydramnios, which is an indication of poor glycemic control. So management in terms of delivery, we normally aim delivery at 38 weeks, and giving steroid to assist fetal lung maturity is usually beneficial. And the delivery can be spontaneous, induced, elective, or emergency CS depending on the individual patient. And the delivery should be done in hospital. So in terms of induction of labor, diabetic women controlled on insulin, that is on insulin, are considered for induction of labor after 38 completed weeks. And women with vascular complications such as preeclampsia, intrauterine growth restriction, require often induction after 37 weeks. So the cesarean section, these are kind of the indication for cesarean section, where we have fetal macrosomia. We already talked about the pathophysiology of this and why it occurs in diabetes. Fetal complications or difficult to control the fetal complications. Fetal compromise is observed in antenatal fetal screening. For example, when we have an non-reassurant fetal status, or early primigravida, multigravida with a bald obstetric history, obstetric complications such as preeclampsia, polyhydramnios, malpresentation. Note that 50% of diabetic mothers are delivered through cesarean section. And then glycemic control during CS and labor. Glycemic control during CS and labor is the utmost of importance to avoid advanced neonatal outcome. It is essential that the blood glucose to be monitored during labor, and our target will be 4 to 7 millimoles per liters. And then during this labor, there's a solution called GKI, which is intravenous glucose, potassium, and insulin. This is an infusion which you give, which comprises of 10% of dextrose in 500 ml, 10 ml of potassium chloride, and regular insulin, that is 10 to 14 units, depending on the blood glucose, to run 5 hourly. So this insulin are going to give, obviously, depending on the blood glucose, to run 5 hourly, and should be prescribed at least at the onset of labor. These infusions are usually useful for glycemic control during cesarean section, but you also give them during the onset of labor. Following delivery or removal of the placenta, then you have the dose of GKI that you give 10% of dextrose, that is, so yes, you have 10% of dextrose, 500 ml, plus 10% of millimoles of potassium chloride. What you have is the insulin. So you're going to give 5 to 7 units of insulin to run 5 hourly to prevent hypoglycemia in the mother. Once the mother is allowed to feed, then you give pregnancy doses of insulin or oral hypoglycemic agents. So care for the neonate. Now we have delivered, and already we have mentioned before that this neonate was in an environment where they had large amounts of glucose. So blood glucose must be done for the neonate at birth, and if the neonate is stable and there is no hypoglycemia, then you initiate breastfeeding. It is advisable to admit the neonate for 6 to 24 hours in the newborn unit if they are hypoglycemic or they are symptomatic. Are they drowsy? So, and then you monitor blood glucose 3 hourly for 24 to 48 hours. And then our aim is usually for blood glucose is usually 4 to 7 millimoles per liter. So if the blood glucose is less than 2.8 millimole, then you give a bolus of 10% of dextrose, that is 2 ml per kg, and feed this patient. So if the patient is hypoglycemic, that they have 2.8 millimoles, then you give a bolus of 10% of dextrose and you feed this patient. And then you monitor for any neonatal complication, and then you ensure breastfeeding has occurred. And for neonate born to a mother who had poor control, especially in the first trimester, should be screened for congenital anomaly. I don't need to explain this point because I've already explained it. Postnatal care, you ensure breastfeeding has been established, and then you see, because we said one of the complications of having diabetes on pregnancy is increased puerperal sepsis. So you ensure surveillance of the puerperal infection, especially on the surgical sites and wounds, and you ensure you give prophylaxis for such kind of conditions. And then patients should go back to pregnancy doses of insulin and oral hypoglycemic agents, and then you perform a random blood glucose test after 24 hours and adjust the dose of the pregnancy doses, and then you maintain blood glucose control between 5 to 9 millimoles per liter, and you encourage this patient to take contraception at 6 weeks. This contraception is to ensure that we don't have risk for unplanned pregnancy, which will predispose this patient on having a lot of complication both on the fetus and on the mother. And then you ensure that any patient with vascular complications should avoid estrogen containing contraception. So if you already know that thromboembolic conditions are majorly or are at higher risk in puerperal compared actually to pregnancy, we avoid this estrogen because already there are risk factor or in its own, and this patient has already vascular complications. So thank you.